All right. So let's talk about the cardiovascular system a bit. As I mentioned, we got a lot of extra blood at the time of the delivery. 1.5 times the blood volume, starting about 30th week or so. So we lose a little blood, hopefully not as much as 500 or 1,000 for a C-section, but there is some bleeding following delivery. And then the natural process is diuresis and diaphoresis. All right, so sweating and peeing. It's a great time. All right. In the absence of any other symptoms, diuresis and diaphoresis is completely normal. I repeat, diuresis and diaphoresis in the absence of other symptoms is completely normal. It's the way the body gets rid of all that extra fluid. All right. Some women will say, my gosh, my feet weren't this puffy 2 days ago, and it's about 24 hours postpartum. It's because all that extra fluid goes out to the tissues first and then gets reabsorbed and through the kidneys and out the bladder, okay? So, in the absence of other symptoms, perfectly normal. God bless you. All right, hypovolemic shock. Not typical, because we are starting with so much extra fluid on board in terms of blood. It doesn't mean that they don't get dizzy the first time they get up. That's more an orthostatic thing. But if you start seeing shock symptoms, tachycardia, shortness of breath, faintness, like without movement, they've lost a lot of blood because they're starting with an excess, and yeah. So that's a problem, all right? But there's a lot of readjustment. All the vasculature, that supplied the uterus and the placenta with blood, has to kind of revert back to the way it was before. To me, it's just amazing. The human body is just amazing. That the fertilization of an egg starts this whole process. We could probably explain it through science, but I really think it's magic. I really do. So that's what we'll say. If you have a question on a quiz and magic is the answer, here we tell you. That's the correct one. Not really, I was just joking for anyone who doesn't catch humor on video. White blood cell count is up a bit. Just think, white blood cells are the warriors, right? The infection warriors in the body, all right? So a lot just happened in that body, and the white blood cell warriors are like on high alert. Like they're ready to go to the source of a breach, if you will, like an episiotomy, a C-section, and it's just there to fight the possible infection, all right? So slightly elevated white blood cell count is simply in reaction to the activity of giving birth. Coagulation factors and fibrinogen levels are also increased during pregnancy and postpartum for the first couple of weeks, 2 to 3 weeks, all right? What does this mean? Increased risk of DVT, blood clots, yeah. We want the blood to clot in certain places, but not in the calf, right? So we're getting these women up and moving very quickly. In fact, it is the common practice in OB for a woman who's having a C-section. She's on the table, on the OR table, and we're putting those pneumatic stockings on her on the OR table. She keeps them on throughout the first few hours, the first 24 hours. 6 hours after a C-section, we're getting her up and out of bed. Yeah, good times. Yeah. We're getting her moving as soon as reasonably possible for them. And this is to help with prevention of blood clots. Once she's back in bed, we put those stockings back on. It's usually about the 24-hour mark that we will take them off and expect her to be up and moving um, fairly regularly.
When can they shower after a C-section?
When their dressing comes off and their IV. Although sometimes they have an IV for longer, we can cover up the IV. But I would say 24 hours. Yeah. Some docs like to keep the dressings on a little bit longer. Depends on what kind of dressing it is. But a lot of places, about the 6-hour mark, we're taking off the pressure dressing, and sometimes it's just a replaceable, call it an island dressing, like a Telfa dressing on there. At the 24-hour mark, they probably think, oh gosh, that might be a little too much work. But man, that shower feels good. I still remember how good that shower felt, the first one. The warm water on my sore tummy and just the back. It felt so good. And so I encourage all the patients at the 24-hour mark. All right, if mom is Rh negative and baby ends up being Rh positive, we might have a little problem, all right? Rh negative blood does not have an antigen in it that Rh positive blood has. The Rh positive blood of baby might get mixed in a little bit with mom's Rh negative blood, which the mom's body feels like it's under attack with this antigen that is unfamiliar. So mom's body will create an antibody to kind of attack the invading antigen. So the first baby is not a problem. The second baby is the problem because mom has the antibodies ready to go. So the second baby, it comes in. If there's any mixing of the blood, those antibodies are already right there and starting to destroy the baby's blood.
Does that mean that there's an increase of like spontaneous abortion?
There's an increase in spontaneous abortions. There's an increase in what we call Rh isoimmunization. But back in 1950s or something like that, with the good work of some smart person and Reese's monkeys, we found that if we gave the Rh negative mom some Rogaine, all right, it's actually considered a blood product. It tricks the body. This is how I like to think of it. Rogaine is like the antibody. It tricks the body into thinking, oh, I already have the antibody. I don't need to make my own. All right, that's putting it very simply, but that's how I understand it. All right, so every Rh negative mother at the 28-week mark in pregnancy gets a shot of Rogaine. We don't know yet what the baby is, but we're going to give her a shot of Rogaine just in case there was already a little mixing of blood. If she's had any bleeding issues early on, or if she had a miscarriage and she's Rh negative, she'll probably get a shot of Rogaine then too. Baby's born, we test the cord blood for baby's blood type. If baby's Rh negative, we don't have to worry about it, right? There's no antigen causing the trouble in mom's blood. If baby's Rh positive, then we draw mom to find out how much blood kind of mixed in, and we give her a shot of Rogaine, appropriate amount of Rogaine based on what we find in mom's blood. This has, in the modern world of prenatal care, eliminated a lot of trouble. All right, I have seen a couple of women who have delivered in third world countries and maybe didn't have access to the best care, who are Rh isoimmunized. So they have the antibody. And so we had to watch them very, very closely during their pregnancy. What we would monitor her for is the baby for anemia. So we're doing ultrasounds. We're doing all sorts of monitoring of the baby to show, to kind of like show us signs of anemia. And we will intervene if we can ahead of time, which means maybe delivering the baby early. There are other things we can do now. We can do blood transfusions and stuff in utero now, not in your normal doctor's office. It's in a high-risk center, but it's pretty amazing some of the stuff they can do now in utero. But RhoGAM is the antibody, or acts as the antibody, tricks the mom's body into not making her own, okay? That'll come up again, I'm sure. The Kleinhauer-Betke test is just the test that we check to find out how many fetal blood cells are in mom's circulation. That's the name of the test. We'll probably call it KB test, all right? If it's more than 15 milliliters of blood, then she gets extra RhoGAM. Yeah.
Is that what they do also when a pregnant mother falls and they take their...
Yeah. Mm-hmm. It's one of the tests we will do.
So this
See if there was any.
So this RhoGAM won't attack the second baby.
The RhoGAM won't. No. No. It's kind of it stays in the system for as long as it needs to. All the blood that all the baby's blood has been removed from mom's system.
Okay.
But it stays in there so that so mom thinks, oh, I don't need to make it. I already have it.
Got it. Okay.
That's, like I said, a pretty simplified way of describing it, but that's the way I understand it. A little simple. Yeah.
So the mom would need this for each pregnancy?
Absolutely.
Okay.
Yep. Most importantly, well, I guess they're all important, but is that first pregnancy.
Okay.
Because it'll get her started.
Yeah.
Also, you start the RhoGAM the first time.
Absolutely. Yeah. If she didn't get RhoGAM and her baby was Rh positive and she created the antibodies, then it's then she's not getting,
Oh, so the RhoGAM won't...
the RhoGAM won't work if she's already created her own antibodies. Okay? That's why it's so important to get prenatal care and figure out what the blood type is. That's one of the initial labs we do on a mother, is find out what her blood type is. So yeah, I think I just said all that, huh? Theoretically, mom's and baby's blood don't mix, but there still can be some mixing. All right. The baby's blood we check, it's called direct Coombs. Mom's blood, the KB test, which we would do probably more during her pregnancy, if there was a mixing. Indirect Coombs for mom, we'll find if there are any antibodies already in her blood. Indirect or direct Coombs on baby, if we find there are antibodies in baby's blood, then the destruction, red blood cell destruction, is already happening in baby's blood. So baby might have a little trouble with like jaundice and stuff afterwards. We'll talk more about jaundice next week. But we just have to be ready for signs of anemia and that sort of thing in baby if the antibodies are already there. This is a whole bunch of what I just said. Pretty much. All right. So those first few hours are pretty important. Not only are we trying to prevent postpartum hemorrhage, we are watching mom very carefully, all right? We are monitoring her vital signs. We are monitoring her bleeding, her fundus. We're making her comfortable. We're starting education. We're encouraging bonding and all that. But vital signs are going to tell us how all this physical adaptation is going, all right? All those changes in the cardiovascular system, like I said, some sort of heart condition may have gone unnoticed until the body is stressed during pregnancy, pushing, and postpartum. I have had patients go into congestive heart failure after delivery. Yeah, a couple days after delivery. There were extenuating circumstances with some of them, but sometimes a woman has a cardiac defect that she didn't know about because it never gave her trouble because she never put her body through this amazing work before. And between the medications we're giving and all that the body has to do, now this is the time that it might rear its ugly head. Shame on us if we're not checking. right? We consider our patients to be young and healthy. Well, we got to make sure they stay healthy. So monitoring vital signs, lung sounds, heart sounds, all that sort of thing is still important, even though we would expect them to be normal when we check. The temperature may be slightly elevated. Just think, man, that woman just did a whole lot of work. So her blood, she might be a little heated up, right? But nothing above 100, all right? So it's going to be less than 100, but a slightly elevated temp at first, completely normal. She might also have a slight elevation in temp when her milk comes in. Like, again, no more than 100. In the hospital, and certainly doctors consider a fever to be 100.4 or higher. So that would be the thing to tell the patient. Blood pressure might actually have a slight increase right away after birth, but we have a lot of orthostatic hypotension. First time up. They're like, I'm fine. Ooh, not fine. Boom, down they go, all right? Yeah, so we don't want that to happen. Women postpartum are actually in a fair amount of risk for fall. Between the epidural that they had, they can move their legs when they're up, and guess what they can't do? Can't bear weight on their legs, but they can move them, so they don't know that until they're bearing weight, right? Or a coordinated movement, like, oh, guess, nope, right? They get halfway to the bathroom, nope, yeah, all of that. So our fall risks in hospitals are more really about the cognitively impaired, meaning the old senile woman versus the healthy young woman who just had a baby. Mentally, she's not confused, she's not necessarily incontinent, and all the different fall risk things that they have. We have this was a pet peeve of mine for the first 22 years of my practice. So I was in management for a fair amount of time, and I had an evidence-based practice group to my disposal, and I wanted to create a different fall risk assessment for OB patients, for postpartum patients, because the one we had, which we are required to do on every hospital patient, was irrelevant. So we were saying these patients were not fall risk, when in fact ours were, and we were having falls in OB. So I put them to work. I did a little research and I found a particular, we call it the egress test, which is it's a fall risk assessment. Actually, a physical therapist, Michael Dion, I don't know, Maryland or something like that he's in, created it to assess his post-op hip and knee replacement patients. Again, they might be cognitively quite aware, but weakened lower legs, muscles and such, not so much. So I got permission to use it, made a slight modification, which he approved, gave him credit for it, and we put it to the test. And we presented it at a national conference, and across the country, you might see the egress test for OB patients. I know they do it at St. Francis. They do it at Hartford Hospital, which is where we started. And there's modified versions of it in different hospitals. Cool, right? So what is it? We get them up, sit them up, let their legs dangle. First, orthostatic. We stand them up right on the edge of the bed, and they stay there for a minute. And they bend and sit back down and get back up again. So we're doing all this stuff. And then they march in place a couple of times. And if after all that, they can bear weight on both legs, and they haven't gotten dizzy and fallen over, then we take a step. And if they can do all of that, then they're not considered a fall risk. Get them to the bathroom, come back. But just that marching in place, we have caught a couple of patients. So it's an effective way to prevent some falls. Blood pressure certainly is one of the reasons why a patient might be at risk for falls. Their pulse might be slightly elevated. Oh yeah, their heart is working quite a bit extra, don't you think? Moving all the extra fluid from one place to another and all sorts of things, right? So slightly elevated pulse, stroke volume, cardiac output after delivery for the first hour or so is perfectly normal. It will gradually decrease to before she was pregnant, by 8 to 10 weeks or so. Did I mention diaphoresis is normal as well? Yeah. Some women, I think some of it's adrenaline, some of it's a little extra like sweating or whatever. They get the tremors or chill, postpartum chill, right after delivery. And the harder they fight it, the more they shake. So tell them not to fight it, maybe wrapping them in a warm blanket and just letting them ride it out will be fine. But I think it's just, have you ever almost got into a car accident or almost fell or almost did something and then it's afterwards that you're a little like, ooh, I think perfectly reasonable. Now, if I did that, not on a video, what would you hear? Ooh. You know what I mean? That's why the video is so important. Let me see how many steps I have. Pretty good. I've gotten 5,000 steps so far this class. All right. So tremors or chills, perfectly normal. After pains. All that cramping and contracting of that uterus to keep the bleeding and everything the way we want it hurts. Yeah, it's cramps, right? The more babies a woman has, the harder her uterus has to work to stay contracted. So first time moms might not feel a lot of cramping, but second time, third time, 19th time, that uterus has to work much harder to get, where it's supposed to be. All right. Some women say, "My gosh, this feels like it's almost as bad as labor." I wouldn't know. I stopped at 1. There is a relaxation of all joints and like all the muscles and stuff need to be relaxed during pregnancy, right? To accommodate growing bellies, relax the pelvic muscles and stuff to allow the birth. Well, it's not specific just to those muscles and joints. All the muscles and joints tend to be a little loose, okay? So it puts them at higher risk for joint injury prenatally and slightly after pregnancy. I will say by the 6 to 8 week mark, the joints and muscles should be back to their pre-pregnant state. Some women have reported that their feet got bigger and they stayed bigger. Anyone have that happen to their own feet? Yeah, mine didn't change size, but everything else did. Muscle tone should be restored due to the removal of progesterone. Progesterone is a smooth muscle relaxer. Once the progesterone leaves after the pregnancy is over, muscle tone should return to pre-pregnant. In terms of the abdomen, I would say conservatively give a body a solid 26 years. 20, let's go 26 and a half years. All right? I mean, I got a couple more months. I've been working really, really hard. My daughter just celebrated her 26th birthday, and I feel like I'm almost there. It's almost back to the fat I used to be. I don't want to rush it, but 26 plus years, reasonable. Some might say 6 to 8 weeks. In fact, most people would say 6 to 8 weeks, but again, pressure, it's off. Okay. All right. Some women actually have a phenomenon called Diastasis Recti. It's our Diastasis Recti muscle, right here, is our belly muscle, really. It's actually two muscles that meet in the middle. Well, sometimes between the relaxation of muscles and the expansion of the abdomen, that diastasis recti muscle splits open. So the space, the seam, if you will, between the two muscles widens. So you get calls from women saying, I think I might be splitting open. And I'm a little concerned. And we talk about this muscle pump. It's clinically not significant, emotionally quite a trauma. Like I feel like any minute now, something's gonna come flying out, right? 6 to 8 weeks should help them recover, and it should go back to normal. I have heard of some patients needing a little stitch or two to actually get it back to normal. But most times there is a spontaneous return. What's that? Did anyone have that happen to them during their pregnancy? Yeah. Very disturbing to wake up and all of a sudden feel like things are coming undone. Yeah, 6 to 8 weeks, whatever. Abdomens are loose and flabby, but they say will respond to exercise. Give it time, folks. Just give it time. Eventually, or gradually, it will return to the non-pregnant state, the uterine ligaments and all of that. Striae gravidarum. It is a fancy word that sounds like a Harry Potter spell. Other stretch marks, yes. Some, they look like little white, silvery slivers. Mine look like a tiger clawed my stomach. It's like burgundy red, like trauma scene on my stomach. I'm here to tell you that has faded to a nice silvery thread, but yeah, you look at my stomach, you're like, whoa, what happened there? Oh, so overall, quite pretty. But they will fade. I'm here to tell you. And as I mentioned, the abdominal wall, 6 weeks to 26 years. We talked about this split in the muscle. If this has occurred, really you should wait 4 weeks before doing any sort of abdominal exercises to give it a chance to heal. Proper body mechanics and posture for all is important, but will help prevent injury for an already vulnerable state. All right, part of the lab work we're doing, we check for rubella status, so rubella being German measles. If they are not immune, some women actually lose immunity. And I don't know if the pregnancy has anything to do with that. I only know pregnant patients, so I've never tested, I've never started an IV on a man. I've never catheterized a man. Isn't that something? Yeah. So if any of you guys are free, I just want to, because I just want to be a better nurse overall. If you guys want to help me out, it's just purely clinical. I'm not being inappropriate. I just don't think I've ever had to. Oh, sure. The IV thing, though, like an adult male, I've been, you're in the grocery store and you're looking at their veins like, I don't even need a tourniquet for this thing. Oh. I'm always getting the puffy pregnant ladies, or the scrawny little newborns. Those adult males, they're standing there like that. I'm like, I could just get an 18 days in there right now. Excuse me. The things you take for granted when you take care of both genders. I'm sorry, video. I hope nobody watches this who's not in my class. They will? Anyways.
You're gonna be a star.
Back to rubella. We're checking rubella. If they are not rubella immune, if they're rubella non-immune, we can't give them vaccine during pregnancy, but we will try to get it to them before they leave the hospital after delivery. It's a live virus vaccine. Live virus vaccines are not recommended during pregnancy, but we do want to know and we want to get it to them so that they are protected. More importantly, their babies will be protected. So babies don't get the rubella vaccine, I think until like 6 months or something like that. So we want to make sure everyone around the baby is vaccinated, all right? Hepatitis B status, we're gonna find out that right away, all right? Again, we can't offer the vaccine during pregnancy, but if mom is hepatitis B positive, then we have to give baby within, usually we're giving it within 2 hours of birth, hepatitis B immunoglobulin, followed by the hepatitis B vaccine. And this will prevent mother-baby transmission of hepatitis B. And we'll just know ahead of time and take precautions to minimize transmission to the baby, like bathing the baby, not breaking through the skin of an unbathed baby, like with a shot or a scalp electrode or anything like that. We'll give Rogan if we need to. That's considered an immune system. That makes sense, right? Well, some practices check for varicella status or chickenpox, and we'll offer the varicella vaccine after delivery as well. It's nice to know if somebody is varicella immune, like clinically proven varicella immune, because I don't know how many times I got called from a pregnant woman saying I was visiting my grandfather, and 2 days later I found out he had shingles. And they freak out, like, am I, in danger of getting shingles? And I go to their lab work and I say, you're varicella immune. You are not, anyone who's varicella immune is not going to get shingles from a person. If they're not immune, they can get chickenpox from somebody who has varicella or has shingles. It's an old virus. Do you know how shingles works?
Yes.
It's a dormant virus that reactivates. Yeah. So it's your own system, but it's an active virus and will shed once it's out. And if you're not immune, there's trouble.
For the rubella, if they give it after the pregnancy, does the baby get the antibodies to the breast milk?
Not enough, I don't think, that to be clinically significant. No. But that's a good question. I don't think it's clinically significant though.
Okay.
The only two vaccines we strongly encourage during pregnancy, the flu vaccine. Pregnancy is considered high risk. All right. Pregnancy complicates the flu. Flu complicates pregnancy. So we want to avoid the flu during pregnancy at all costs. The Tdap vaccine. All right, it's about pertussis. All right, pertussis vaccine, or DTaP, I think, is the vaccine for a child, and they don't get that at least till 6 months, if not a year. I don't remember you'll learn that next half. Sorry, I don't know it. Ask Robin. She's the smart one when it comes to that, not me. Tdap vaccine, again, it's kind of like the rubella, but even more so. We want to cocoon the baby, surround the baby with vaccinated people, because whooping cough, or pertussis, is making a comeback, all right? You and I can handle it, although we'd whine quite a bit. We can handle whooping cough. A newborn baby cannot, all right? And it's the newborn baby that is completely vulnerable and unprotected. So we gotta get everyone, daycare providers, nurses, moms, dads, grandparents, older siblings, who I hope are already immunized, but we should all be revaccinated to protect the babies who have yet to be vaccinated, okay? It's strongly encouraged during pregnancy, the last trimester of pregnancy, and studies are now showing that a possible small amount of immunity may pass on through the placenta to the baby, and there is a small level of protection that they might actually have if it's given during the 3rd trimester of pregnancy. Now, we are on to chapter 18, So we talked about the physiological or the physical adaptations. Psychologically, I don't know about any. How many people have kids? Male, female?
Kind of.
Yeah, you got. There's quite a few. I don't know about you guys, but it's the hardest job I have ever had, and I knew what I was doing. Meaning, I knew the physical stuff of how to take care of a baby. I was teaching new mothers how to take care of their newborn babies, how to breastfeed, how to take care of themselves. And it was the hardest job I've ever had. And all I could think about was, oh my gosh, I know what I'm doing and this is hard. What about the people who had absolutely, starting from like ground zero? You know, like changing a diaper takes emotional and physical energy to do because you're so not practiced at it. It's hard. Throw in lack of sleep, physical exhaustion, and hormones. Yikes. It's amazing that we've all survived. Some of y'all have done it more than once. I figured that out real quick, and I only had one. I'm just kidding. Stopped it perfect, just in case my kid's watching. So there's an adaptation that is pretty typical that you'd see, I think partially hormone related, partially just human related, all right? The first stage of adaptation, if you will, is called the taking in phase. We got to talk about it a little bit. We got to be a little self-centered, like, oh my gosh. It's like, whew. Okay, can I order dinner? Can I do this? They're a little self-centered and needing it to be a little bit about them, and that's normal, all right? You might sit there and have charts and flow sheets and music to your presentation about a certain educational material. 2 hours later, they might ask you the same question over again. It's because they didn't absorb anything you're telling them. That's the taking in phase, okay? It's the first day or so after delivery. Well, by gosh, that's not very convenient. Where are they for the first couple of days? In the hospital with nurses trying to teach them. You can see where that might be a little bit of a challenge for us, right? That's why we have to reiterate the information we're giving them. Give them stuff they can take home, a link to a video, a written material, whatever. Also, that's why I say include more than just her in the teaching. Because her husband's not in the taking in phase, nor is her mother, or whatever. Get more people involved in all this education so that they can be there to kind of reinforce it when all of a sudden they go into the taking hold phase, which is the next one. They're already home by then, wondering what the heck happened. All right? Taking hold phase. Now they're ready. Okay. Oh, where did they go? Wait a minute. What do you mean I'm home? You know? Taking hold phase, day 3 to 10. All right? They're very responsive to teaching about herself and her baby. So this might be when she reaches for that material that we gave her in the hospital. And then the interdependent or the letting go phase. This is, all right, we've kind of mastered some of the simple tasks and whatnot, and maybe it's time now that she has to go back to work or resume other activities within her life, adding motherhood to it. It's still hard. I don't care who you are. Probably, not only was it the hardest, or is the hardest job I've ever had, it's the most important job I ever had. Right? For all you parents. And you don't have to be a parent to think that, wow, this tiny human's life is in my hands. I got to make the right choices to keep them physically safe, emotionally safe, to help them succeed, to do all these things. You put way too much pressure on yourself. I know I think it was the placenta delivered, and I immediately set expectations way too high for myself. Right? Anyone else? Or is it just me? My mom became the perfect individual that I strove to be like, and I knew I could never ever get to, no matter how hard I tried, no matter what I did. Well, turns out my mom was feeling the same way when she was in my spot. But you don't see that. You see the perfect. That's what you strive for. And my gosh, I'm failing, right? Throw that on top of fatigue and all the hormones. Yeah. Yeesh. It's amazing. It's amazing that we all survive. The issue is people need to know that that's okay. That it's hard. It's hard. Even if you think you know what you're doing, it's still hard because it's so important. And yeah, we need to ask for help. But more importantly, you guys, as nurses, as friends, as sisters, as mothers, as daughters, you have to offer the help, right? You need to say, I don't know about you, but motherhood's tough. I found, it was tough. And I felt pretty lousy for a while. How are you feeling? Invite them and give them permission to say, yeah, I'm struggling. It is hard. Because they start feeling bad about themselves. Throw on fatigue, throw on hormones, throw on the physical and emotional stress of all of this. And you know what? I thought I wanted to be a mom, and I thought I'd be good at it, but this is not what I expected, and this is not what wow, maybe I shouldn't be this. Maybe I'm not cut out for this. Well, all right, so we got the fatigue, we got the stress, we got the hormones. Now we have embarrassment and shame. Throw that on top of it. Because now I don't feel worthy of the job that I have. And so I'm ashamed to tell somebody that. And I'm embarrassed because I think I'm not good enough. Do you see where this can be a problem for somebody? Do you see where you can help as friends, as sisters, as mothers, as daughters, as cousins, as nurses? You need to say, it's okay to feel that way. What can I do to help you? And just start the conversation. Because those feelings can turn into something much more damaging down the line. Postpartum blues is perfectly okay. It's normal. It's the hormones. It's the fatigue. I think each one of you who has had a baby or known somebody close to you who has probably knows what I'm talking about. For those who have had the courage to ask your loved one or your sister or whoever, it's very easy to see how somebody could kind of spiral out of control to the point where it's not just postpartum blues, but it's full-out depression, all right? That needs intervention. That needs intervention. That needs medications. That needs therapy. That needs intervention. If we can start the conversation before the feelings begin, continue the conversation, and get them through the initial feelings of fear, stress, embarrassment, shame, hormones, maybe they won't get to that low point in their life, all right? But if they do, then they know they can say something to get the help they need, all right? Postpartum is tough, plain and simple. I don't mean to bring people down, but that's how important it is. As an OB nurse in the office, I called all of the patients at the 2-week mark. And I kept a note when they delivered and put it on my calendar. And I would say, hey, I was just thinking about you. Whether I wasn't, yeah, I was thinking about you because I saw your name on my calendar, but neither here nor there. I was just thinking about you, and I wanted to call and see how you were doing. And I'd ask them questions about their physical self. But I said, it's a pretty tough job. How are you feeling? And I started the conversation if nobody had already felt it. It was that conversation that got several patients in early to see the doctor and get them help. And those patients got put back on my calendar and called every week until I felt like they were ready to fly. So that's how important it is to me. So if I have at all passed on any of that to you, my job is done. Needless to say, it's tough. Constant vigilance, because you're trying to figure out if this little creature is safe and all sorts of things.
You're gonna like fuck them up. I mean, mess them up. Sorry.
Oh yeah, no, I know. My baby stayed in a bassinet at the side my bedside for like 3 months. Every little noise I heard, right, and I knew what I was doing. Baby went into the other room, into her crib. The first night was tough because I just kept getting up and looking. But that second night, man, did I sleep well. Oh, did I sleep well. Because she survived the first night. Ooh, there's something to this. Yeah. You throw in other roles like mom to older children, wife, friend, all sorts of things. You got yourself some challenges. We want to promote bonding right away. Skin to skin, right at birth, gets it started. So that's pretty cool. It's helpful to mom and it's very helpful to baby as well. Temperature regulation, bonding, heart rate regulation, breathing regulation, all sorts of things. It's the right thing to do. We want to promote rooming in so that we just get the whole getting to know you stage started, okay? If they are choosing to breastfeed, let's get them started right away. So that's good. Teaching both mom, dad, and other family members, infant care is great. Encourage the family, particularly mom and dad, encourage that bonding to happen, and certainly encourage expression of feelings. Dad goes through a period of adaptation too. We call it engrossment. And, it's about expectations and reality and then transition to mastery. All right? They have to kind of feel it out for themselves too. And maybe they're used to knowing everything. Maybe they're used to kind of being the center of his wife's world, say. Now all of a sudden, the baby comes along, and that seems to be more everyone's focus. And it doesn't mean that he's going to react negatively, but he just needs to kind of adjust expectations a little bit. He wants to know what he's doing. He wants to be able to be helpful. So we need to consider his feelings and help him master them as well. Culture and previous experience have a whole lot to do with how the family reacts, all right, or behaves in labor and delivery as well as in the postpartum setting, all right? I don't pretend to know every culture. I will say that the Middle Eastern culture, and if somebody knows different and wants to enlighten us, by all means do. But the Middle Eastern culture is it's more a maternal thing, so the mother and mother-in-law will kind of step in and kind of take over care of baby and will take care of the mother, the new mother. The father is present by all means, and it does not reflect how he feels, but he's basically kind of off to the side a bit, present, but does not appear to be emotionally engaged to what's going on. And that doesn't mean he isn't emotionally engaged, and it doesn't mean I should judge him because my culture is different. It just, everyone is doing what is culturally expected of them, okay? So no matter what field of nursing you go into, be familiar with the cultures that are common to your patient population, all right? Particularly around birth and death, lots of different cultural customs and whatnot. So I think it can create a more comfortable arrangement if you are familiar with what's going on for both you and your patient and family, because you could inadvertently judge or offend your patient and family because you're not familiar with what's going on. Does that make sense? All right. So keep that in mind when you see something. When you see something concerning, step back and look at the whole picture to see if maybe it is a problem, or is it a, kind of what is expected of their particular culture. But I think that really encouraging the father-baby bonding is very important, no matter what culture. Acknowledging the father and helping the father with tasks is important. Where we had taking in, taking hold, and letting go. For a dad, we call it making a commitment, becoming connected, and making room for the infant. Pretty much the same, just I don't know why we have to create different phrases for it, but that's that. Siblings, I'll tell you what, 2.5-year-old who's had his or her parents all to his or herself might, oh, baby, they might be able to, with the doll, this is my baby, mommy's baby's in her belly, whatever. Then all of a sudden, baby's out, oh, and then, wait a minute, baby's coming home. So now, wait a minute. I have to share my mommy and daddy? Wait a minute here, So a lot of hospitals actually have classes for older siblings where they bring their doll and they see where mommy and daddy are going to be and all sorts of things. Sometimes mom in the hospital having their baby, it's the first time she's been separated with her other child. That's traumatic for everyone involved. So there's different things we can do to help with that transition for the older sibling. There's education. There's, preparation in terms of those classes and seeing where mom is going to be, setting up a plan where they have some special time with other relatives. There are making sure that you still take time one-on-one with the older sibling, not just include the older sibling in with the baby's time, but that older sibling needs mother time and daddy time. All right. A common intervention to help with a sibling adaptation is buying the child off. I have seen many older siblings get a present from the new baby. That's buying them off, am I right? Buying them off, ooh, I think I do like this baby. He gave me this truck.
My 4-year-old is waiting for his Buzz Lightyear from his baby brother.
See? That's what it's about, right? This kid has got it figured out.
Every
He
day
starts-
in the mail, he always asks, is this Buzz Lightyear? Just waiting for it to come.
Absolutely. So, now this child is smart. This child is above average smart. You know why? He's putting in his order from the baby brother.
Oh, yeah.
Oh, yeah.
He's a smart one.
Yeah. So, anyways, that's all I have to say about older siblings. Discharge teaching. Again, the biggest challenge is that we have 2 or 3 days to teach mom and dad and everyone how to take care of themselves and their baby during the most difficult time to do that thing of teaching, taking hold, taking in, all right? But we still are obligated to check off our education checklist, okay? It's important to know how a patient learns best. Is it hands-on? You can talk all you want, but unless they're hands-on doing it, they might not really absorb the information. So find out. Have a conversation with them. Do you want to just jump in and help? I'll be right here to show you what's going on. You want to watch the bath first, and then tomorrow we can do a bath? Like, just find out how they learn best. Don't make assumptions. Don't assume that a second-time mom knows how to take care of a circumcision. Because maybe that first baby was a girl. Or maybe it's been 8 years since she had a baby, and she does not remember anything about the newborn period. Maybe she bottle fed the first time. And if we're saying, well, you've done this before, then she's like, well, actually, I don't remember. She's not going to do that, all right? So you can just carry on as if she doesn't know. And if she says, oh, no, yeah, I remember, then fine. But don't assume she knows. Assume she doesn't know, in other words. So that eliminates mother feeling like, oh, gosh, should I remember how to do that? It was 8 years ago, or whatever. When you include the older generations in particularly the child safety stuff, the child care stuff, God bless you. I think it's important because some child safety recommendations have changed since Grandma had her baby. Now, Grandma wants the absolute best for her grandchild, which means bundling them up, putting them on a pillow on their belly. Guess what? None of those things are recommended anymore. That doesn't mean Grandma's trying to hurt the baby, but that's what she did in her time, and her babies were fine, right? So having Grandma there to learn about safe sleep patterns and what is expected at what time and the breastfeeding and all of that stuff will save some confusion and some hard feelings. Because Grandma wants the best. And if Grandma hears this, she might be like, oh, okay, and then encourage that. But if we are telling Mom and Dad, back, the baby should be on their back sleeping, there shouldn't be any pillows, it needs to be a firm surface with good airflow, don't overwrap the baby, all these things that we're telling Mom and Dad, and then Grandma comes along, and the expert, right, the matriarch of the family or whatever, and does the exact opposite of that, and you're like, I love you, Grandma, but that's wrong. God bless you. Who's going to do that, right? Who is going to do that to Grandma? And like, well, who's right? The matriarch of my family or that chick I spent a day and a half with, right? So, that's tough. Education is so important that we have to make sure they understand us, right? And the 6-year-old older sibling who speaks English because they're in the school system now is not a good translator, all right? Because they might not know what perineum is in their language or what that is, all right? So we need to use certified translators legally for discharge instructions as well as consent, all right? Those are the 2 times that we cannot use a family member unless they're a certified translator. Or an interpreter, as we call it, for discharge instructions. That doesn't mean every time you're teaching. You might be able to but when you are checking off the list that they're signing, that they received this information, it's a certified interpreter that you go through. All right, that's the time to be like, oh, wait a minute. That's not what I understood when you went through my, 8-year-old son or whatever. For the little things, are you uncomfortable? This is, use what you have, but certified interpreter for consent and discharge instructions. They got to know about all these things. We talked about all of these things already, huh? All right, so go out and teach it. Kegels. There are a couple of things we need to talk about. Perineal care. Kegel exercises, everyone know what they are? For those who don't know, a Kegel exercise, it's using the muscles of the hind end, if you will, the down belows, as they say in 1950s England, my down belows. Does anyone want to call the midwife? That's how the down belows? No, okay. Well, now you will call it that, right? From now on, my down belows, my DBs. My DBs. That's what we're calling it, folks. I'll stop saying vagina, maybe. The DBs. All right, my DBs. So it's using those muscles. Have you ever been, you're waiting for an important phone call, but you have to pee really bad, so you take the phone into the bathroom with you, and you start peeing just when the important phone call comes? You don't want to be peeing like full force while answering the phone, so you stop peeing. You know those muscles you use to stop peeing? That's a Kegel exercise. All right? Kegel exercises are good. It promotes circulation. It promotes elasticity of your muscles to prepare for childbirth and to kind of recuperate from childbirth afterwards. All right? So there are good things to know how to do. And a man can do Kegel exercises as well. So get going on it. In terms of exercise, it's probably a good time to bring up. You know, some people are like addicted to jogging. You know, the runner's high, that sort of thing. Some people like have to exercise. I don't know if it's an endorphin thing or whatever. The runner's high.
I feel like you're floating.
Floating, okay. I guess we've known each other now for a few hours. I think I'm comfortable in telling you that I am addicted to Kegel exercises. I'm doing them right now. And while I don't want to force or peer pressure you into a negative activity, I might at some point, if I feel like one of you is drifting off a bit, I might say, hey, drop and give me 20. And I don't mean push-ups. All right? Nick, give me 20. Now Nick has to do 20 Kegels. All right? So I'm going to look, see if anyone's if I'm losing them. Boom. 10. All right? If I'm losing all of you, I might say, okay, everyone, stand up and give me 15. All right? Kegel exercise. Hemorrhoids. That picture, I think, says it all. But there's different things we can do. Kegels help. Lying on their side to prolong all of that. Stool softeners, fluid intake. Topical anesthetic ointments, witch hazel pads, sitz baths, all of that can help with comfort and swelling. After pains, if we keep the bladder empty, that helps the uterus. Doesn't have to work so hard to contract. All right, we might have to do that massaging, which might add to it. If a woman's laying on her side, have you ever seen some women wear an abdominal binder after delivery? Yeah, we encourage it with a C-section, but even vaginal delivery patients sometimes wear them. I see it more in different cultures, but it helps with contractions because everything's kind of being supported, so the uterus is kind of where it needs to be, so it doesn't have to work really hard to kind of get in position and yeah. But if they're laying on their side, maybe supporting their belly underneath them also keeps it kind of where it's supposed to be also. How about the muscle aches? Again, you felt okay. Maybe you got into a car accident. Not near miss, but you actually got into a car accident. You felt fine right after, but you woke up the next morning hurt. Like your whole body hurt. Well, it's because the adrenaline has left your body, leaving you to realize about all those muscles you tensed in the crash. Welcome to the second day postpartum, right? Adrenaline's gone, and now my whole body aches, right? Early ambulation can help with not just thrombophlebitis or DVTs, but can also just help get those sore muscles working again. If a woman chooses not to breastfeed, that's okay. The best thing she could do is wear a tight sports bra. She could use ice packs to keep down any swelling, engorgement, for comfort as well. Avoid stimulating, because sometimes, even though she's not breastfeeding, the milk can still come in day 3 to 5. Well, that hurts, plain and simple. It hurts. And what mom wants to do is just relieve, she feels like her boobs are going to explode. So if I could just relieve a little of the pressure, then it'll feel better. No? Yes, it might, but it's just going to prolong it. So avoid any stimulation of the breast. That's why a nice tight sports bra, ice packs. Keep your back to the warm water in the shower, because man, nothing feels better. Whew. Oh. All that's doing is telling your breast, I want more milk. That's stimulating the breast. It's a supply and demand system. If we do not demand, it will stop supplying, okay? So avoid heat of all kinds. And it's a day or two of discomfort, but it will get better. Yeah. How many times have you heard, rest when the baby rests? How about, no, right? How about, let's come up with a plan that gives you a little extra rest in your day. What can we do? Who are you willing to allow, willing to allow to help you? Is it just your husband, or is there somebody who can come and maybe just cook your dinners, or come up with a reasonable plan for the patient? Talk about it. Because just saying, oh, just take a nap when your baby's sleeping is not, it's said, oh, okay. Well, now what? Because that's the only time I had to freaking shower or pee or make phone calls or whatever, you know? And people want to be there. People want to visit. People want to meet the new baby. But really, all the visit is one more thing for the new mom and dad to have to do. So spread the word, folks. You can come visit, but bring casserole with you. Or while you're there, say, I am not leaving until you let me throw 1 load of laundry in and switch it before I go. Something. You know, you guys have to help your friends and family. But setting up a plan, a reasonable plan for each individual patient might make a little bit of a difference for them. All right? No heavy lifting for at least 3 weeks. Don't sit for prolonged periods of time because of the DVT risk. Limit stair climbing. If you've had a C-section, you really should wait 4 to 6 weeks before performing any strenuous exercising, lifting, and that sort of thing. If you're on opioid medication, don't drive. I say let your bleeding be a guide. So if your bleeding has decreased to just a little bit, you still have to wear a pad, but it's not that much, and you're feeling really good, and you actually went out and did some visiting, stopped at the grocery store, you did a couple of extra things, maybe threw a load of laundry in, all of a sudden you're bleeding a little bit more, that's your body saying, guess what? Doing too much. Because that open wound is getting aggravated, okay? So tell your patients, let your bleeding be your guide on that. A diet high in protein, well-balanced one with adequate calories will certainly aid in tissue repair. Got to make sure it's adequate hydration. 2 to 3 liters of fluid per day from food and non-caffeinated beverages. God bless you. For any more information, by all means, check out page 130 in the ATI book. That gives you more details about calorie intake and all that stuff. 26 years, again, is reasonable for the resumption of sexual activity. Some may say 6 weeks, some say when the bleeding stops. Take your pick. We already talked about blues versus depression in terms of postpartum. I will say depression, is, the book describes it or defines it as intense and pervasive sadness with severe or labile mood swings, all right, that persists past the baby's first few weeks of age, all right? A woman can hide it well, all right, but not so well if you're right face to face and asking her specifically how she feels, and putting words to what she might be feeling, all right? So depression happens in 10 to 15% of new mothers. Let me rephrase that. 10 to 15% of new mothers are willing and able to admit that they have depression. I think it's way more. It rarely will disappear without some sort of help. Meds, counseling, that sort of thing, all right? Prominent feature, they say, is rejection of the baby or abnormal jealousy, resentment of the baby. Like, I don't know so much about that. I think that happens sometimes, but I think they almost resent themselves for not meeting their own expectations. Like, I don't know, sometimes it's as actual resentment of the baby for making her feel that way, but I think it is more concern because she doesn't feel like she thought she should feel towards her baby. Obsessive thoughts about harming the baby, that's very typical too. She's feeling bad about her ability to be a mother. So naturally, it's probably easier for her to take the next leap to say, if I'm not a good mother, what am I going to do to my kid by accident? This sort of thing. All right? If she's feeling really bad, she's having obsessive thoughts about harming herself. All right? We want to make sure she's safe from herself, and is her baby safe? All right? But most likely, she's not going to say. She's not going to volunteer that information. All right? You need to point blank ask them. All right? Depression may be present with or without psychotic features. Sometimes what we call it's a postpartum psychosis. I have, we didn't necessarily, I mean, usually this is after the 2-week mark. A woman can have a complete psychotic break. I had a family, lovely, lovely family. First baby, 2.5 weeks postpartum. Her husband brought her to the emergency room. She thought she was the Blessed Virgin Mary. Completely psychotic. They sent her to OB.
She's pregnant?
No, she had delivered 2.5 weeks before. So they sent her to OB. At first, I'm like, what? You're sending a psychotic patient to OB? Probably not a very good idea, but you know what? It was the best idea they could, because the woman who was in having a psychotic episode was cared for by the psych doctor and, the practitioner, and given a safe place until she was admitted to an inpatient center. But we were able to care for her husband and her baby, who were absolutely devastated. The husband was absolutely devastated, and I don't blame him, because his wife showed no signs of psychosis. She was getting a little bit odd, and then she was getting a little paranoid, he thought, maybe, looking back. And then all of a sudden, she was the Blessed Virgin Mary. And at first, I think he thought she was joking, and she was not. She spent a couple of weeks, 2 to 3 weeks, I think, inpatient, and came back about 2 months later to visit us, which was nice because she was healthy and happy and recovered from which is a real thing. You hear about women killing themselves and their babies, and a lot of I cringe when I hear about it. What I cringe even more is hearing the judgment in other people. I'm not saying they should kill their babies. They're saying this woman was evil. No, I think she was sick. I think she was probably sick, not evil. And who am I to judge? But I just feel for them because I saw it with my own eyes. This lovely, healthy woman was completely psychotic. And if left alone, she very well might have hurt herself or her baby. You know what I mean?
What about women
They are more likely to, yep.
the
Mhm.
pregnancy.
They are definitely more likely to suffer from postpartum complications.
Even if they're already on medication for it.
Yeah, there's some medications that we actually try to get a woman off of during pregnancy, but we got to look at risks, benefits. We definitely, if they are off, say Zoloft, early in the pregnancy, while the cardiac system develops, I guess. We might do a fetal echocardiogram just to make sure that things are good. They might start the Zoloft back in the third trimester or late third trimester, and definitely if they haven't, they're starting her day one postpartum back on her Zoloft. Some have had periods of depression or earlier in their life. They are more at risk for postpartum depression as well, or psychosis. They might not have had a psychotic issue before, but if they had any mental health bumps along the way, they are at higher risk for psychosis or depression. Thank you for bringing that up. When should you call? Like we said, fever of 100.4 is what I consider, what everyone considers a fever. So if a woman has a fever of 100.4, if there's a major change in her lochia, the foul smell, it's back to bright red, or it's back to a heavy amount, or even just heavier than it was, if it hasn't stopped in the moderate flow, the moderate dark red flow, and it's day 6, okay? If she has a wound infection or signs of a wound infection, which means we have to teach them what signs of wound infection are, right? Mastitis is an infection of the breast, which, whew, man, that's tough business. That hurts. Yeah, it's like they feel like they have the flu and their boobies hurt a lot. Urinary tract infection. Oh, that's important. They need to know what signs and symptoms of DVT or thrombophlebitis are, right? Continued severe or incapacitating depression. I've already talked to you about that. Please don't wait till it's severe and incapacitating. You know, let's get them talking about it before that. Inability to care for themselves or their baby for whatever reason. They need to call the doctor on it. All right? We'll talk about infant care and safety next week. Just a little review, pharmacology-wise, because we've talked about a lot of things, but I just want to kind of bring it back to some of the medications we talked about. All right? Oxytocin, I don't know how to pronounce that word. On page 118 goes into detail about Pitocin, which is oxytocin, all right? Methergin, or that big long word there. The key with Methergin is you can't give it to high blood pressure, all right? We talked a little bit about Hemabate, just a drug that has side effects like diarrhea and all sorts of fun things like that. Needs to be refrigerated too. It's just not a drug we give first line defense, okay? Misoprostol or Cytotec, important to just be familiar with those 4 drugs. What technically is not a drug, but a blood product is Rogam. Be very familiar with what we talked about in terms of Rogam. And just the vaccines that we kind of reviewed, just know that they are something that we are concerned about. Yes?
You said the most important vaccines were the flu and Tdap?
During pregnancy, we allow them during pregnancy.
Just those two.
Those 2 are the only 2 vaccines we will give during the pregnancy itself. As long as it's the deactivated virus, flu virus. You know the flu mist, that's actually a live virus, so we won't give that. It's a shot. Any questions? Who's gone to clinical? Yeah, so quite a few of you already. You're going to see these terms. I just want to go over them with you. Gravida and para. Gravida is the number of pregnancies. We'll go into much more detail on this, but you're going to see it in a chart. And I want you to not feel so overexposed or overwhelmed. Gravida is the number of pregnancies a woman has had. Para is the number of deliveries after 20 weeks. We break down para a little further to TPAL. We'll talk about that in a couple weeks. You might see 4 numbers after the para, which talk about term deliveries, preterm deliveries, abortions or miscarriages, and number of living children.
Was after how many weeks?
20. Yeah. GBS is group beta strep. It's a common bacteria that's kind of found in the amongst the normal flora in the vaginal rectal area. Every patient is tested for it. If she is positive, she gets penicillin during labor. It doesn't usually cause trouble for the mom, but if baby catches it on the way out, cause major trouble for the baby. All right, sepsis and up to death on a baby. So you'll see GBS everywhere. You'll see GBS negative, GBS positive, and you're like, what the heck is GBS? Now you know. NSVD is a normal spontaneous vaginal delivery. C/S, C-section, right? Primip is, you'll hear people being described, oh, she's a primip. That means this is her first baby. She's delivering her first baby, full term. Multip, not her first baby, all right? Those are just a brief rundown on some lingo or abbreviations you might see when you're in the chart or listening to report. Oh, come on, we have 20 more minutes.
The results for the answer key for the crossword puzzle